this talk, so it probably is on a level where you probably give it the most, the interns and residents about what stress testing is and what different choices are, and you may have more nuts and bolts questions about, the specifics of, meds and things like that, and what the whole and things like that. We can talk about that. But I'm just gonna go through, cardiac stress testing and, review some of the various types of stress tests that are out there and some of the terminology and concepts associated with that. And we're gonna be reviewing exercise treadmill testing. This is not your eyes, these slides are some of them are like funny like this. Myocardial perfusion imaging, which is nuclear stress testing, so MPI is the abbreviation for that. And that's both exercise and pharmacologic stress, myocardial perfusion imaging, and stress echocardiography. And what's the purpose of a stress test? It's really most commonly used for the detection of coronary artery disease, right? So in patients with chest pain syndrome or symptoms that may be anginal equivalents, you want to kind of see whether or not those symptoms are compatible with coronary disease. Sometimes we know patients already do have coronary disease or diagnosis of coronary disease, and we're doing the test to assess the efficacy of medication therapy for people that are being treated with beta blockers or nitrates, calcium blockers for angina. Is that effective for managing their coronary disease, or do they still have a lot of ischemic abnormalities despite medical therapy? And then, some of the things that we've learned from these tests, what is the risk for sudden cardiac death, what's the risk for heart attack? Sometimes it's not really about, sometimes it's not about, thank you. Sometimes it's not about looking at coronary disease. Sometimes we're looking for heart rate response with exercise, or patients who feel fatigued or short of breath with exercise. And when they walk, their heart rate doesn't go up appropriately with exercise. So they have this thing called chronotropic incompetence. So it's not a circulation problem or coronary problem. It's an electrical problem we're evaluating with exercise testing. So there's a number of reasons why we'll do stress tests. Again, the most commonly used reason is really for the detection of coronary disease. And when performing this chest pain workup, we have to have a method to what we're doing, right? So step one is to assess what the chest pain is about. And part of that is determining what the pretest probability of coronary disease is. And I talk about this a little bit in this talk, so you'll see this. And for me, that's kind of an important discussion point. What is the likelihood that someone has coronary disease when you're doing treadmill testing? If you have a 20-year-old who's a cocaine addict, the likelihood of having, or maybe not cocaine because there's different issues, but let's say a 20-year-old who's got anxiety, the likelihood of having coronary disease is really, really low. So you start doing stress testing on patients like that, very low risks of having coronary disease, you start getting a lot of false positive tests in your patient population. So we'll discuss that a little bit. And then, based on the pretest probability of coronary disease, what's the right thing to do? Is the right thing to do a stress test? Is the right thing to cath a patient? If the pretest probability of coronary disease is very high, you have an 80-year-old guy who has high blood pressure, diabetes, hypertension. Every time he walks from here to the bathroom, he gets chest pain that goes away when he stops. I mean, the likelihood of that being coronary disease is super high. So treadmill testing in that situation really probably doesn't offer a lot of benefit, probably some risk, right? So on either end, people that have really high pretest probability of disease, a patient like that, or you're getting your 20-year-old who has anxiety, these people are probably not the, oh shit. These people are probably not the best candidates for treadmill testing or stress testing, and they probably look at different approaches to them. The 20-year-old maybe PARS, and the 80-year-old maybe right to cath. So when we're assessing pretest probability of coronary disease, we're looking at the type of chest pain the patient has. They have non-coronary, so they determine that on the basis of a couple characteristics, right? So non-cardiac chest pain means the patient doesn't have exertional angina, it's not relieved by rest, and it's not this typical characteristics of pain that you get when somebody has angina. That means like a pressure or heaviness, not a sharp stabbing pain over here. So somebody who has a pressure or heaviness that's provoked with exertion, relieved by rest, or nitroglycerin, that's pretty typical in angina. If they have two out of those three characteristics, maybe atypical is the definition for that, and non-cardiac, really only one of those three things. or none. And this is a thing I show a lot when I'm talking to the residents about stress testing or whatever. But if you look at these things, what is the pretest probability of coronary disease based on symptoms, gender, and age? So look at this. You have a 30 or 39-year-old female, right, who has atypical chest pain. So 2 out of those 3 characteristics for angina. The likelihood of coronary disease is less than 5%, as opposed to a male, where it's an intermediate likelihood. So, depending on age, sex, the numbers change, right? As you get to be past menopause, everything's kind of the same, right? Pre-menopause, it varies where the males have a higher likelihood of having coronary disease based on the type of angina they have. So, somebody has a really high pretest likelihood of coronary disease, greater than 90% chance there's going to be blockage. And then these very low numbers, less than 5%. And intermediate likelihood, 10 to 90%. And that's the patients, these intermediate patients, are the patients who are optimal for stress testing. These are patients we want to do stress testing on. Hospital patients are kind of a little bit of a different breed than the patients that kind of run into these kinds of things. These are really more the outpatient things. The hospital patients already kind of declared themselves as unstable pattern, right? That's why they're being admitted. They're not coming into the office telling you, I've got a little chest pain, I'm not sure what it is. They're coming in saying, I had chest pain bad enough, I had to come into the hospital, I got nitro, maybe I got relief, I didn't get relief. My troponin was 0.06, they kind of run themselves in a little bit of a different category, but this is typically how we look at it in the outpatient setting for the most part. And then, why is pretest probability important? Again, the low pretest probability of coronary disease, 5% likely to have coronary disease, and the positive predictive value of a positive stress test. The likelihood that a positive stress test is going to show coronary disease, 21%. So you get a lot of false positives, right? So you don't want that. We don't want to send those people to cath lab. And again, you can see the differences as you get to high pretest probability, right? Here's the high pretest. Somebody who's 80 years old has a lot of typical characteristics for angina, and they have a negative stress test. Still an 83% chance that they have coronary disease. See, really, the decision, I hate the fact that it's flow diagram. It really should be thoughtfully approached. Approach the patient, have a discussion with them, kind of see where they are, where they fall in these characteristics, and then how many risk factors do they have, what's the presentation, and then make decisions based on that. And a lot of that is, this is bread and butter decision making for stress testing, and then determine what kind of stress test we're going to do. Is the patient able to exercise? I don't know how to make a flow diagram on this, because I'm going to tell you how I kind of think about this. I thought we'd have a board, but I don't think we do. But, can the patient exercise? We always want to exercise when they can exercise. Unless they have a left bundle branch block, they have a pacemaker in place, they're on digoxin, or they have a really abnormal resting EKG. Sometimes people with full Parkinson White have funny EKGs. Those people have really uninterpretable EKGs for treadmill testing. So we always put them on the pharmacologic testing, because treadmill testing in people who have pacers or bundle branch block are the most common things. It creates false positive tests that are uninterpretable. So we use pharmacologic testing in those people. And again, what's the resting EKG look like? What's the clinical indication for performing the test? The patient's body has this. If he's 400 pounds and they can't walk, after they do a treadmill test on it, and then the history of prior revascularization. What does that mean? It means, if they've had prior bypass surgery, prior heart attacks, you're probably not going to do a plain treadmill test on somebody for that, and you're going to decide whether you're going to do a stress echo or a stress nuclear study. And there's pluses and minuses, different ways to do that, and I'll go over that as we keep going on here. Duplicate slides. Okay, so this is what a treadmill looks like. So what is a treadmill? So basically, you're going to exercise somebody on a protocol, and there's multiple different protocols, and the heart rate and the blood pressure is going to go up as they walk on the treadmill. That's what's supposed to happen. The heart rate and blood pressure should go up, and we'll talk a little bit about that. So the normal response is that the blood pressure is supposed to go up. The systolic blood pressure is supposed to go up 20 millimeters of mercury, at least 20 milliliters of mercury. And normally the systolic blood pressure will go up and the diastolic pressure will come down. You'll widen your pulse pressure with exercise. And your heart rate will go up. And normally the heart rate will go up appropriately and then come down appropriately in the recovery period. As your heart rate goes up and your blood pressure goes up, that increases myocardial oxygen demand And if there is a circulation problem or coronary blockage, you're not gonna be able to, or your heart won't be able to get enough oxygen to meet the metabolic needs, and you'll develop abnormalities, EKG abnormalities, eventually chest pain. Chest pain is probably the last thing that happens in the ischemic cascade. Usually it's, diastolic dysfunction, heart muscle gets a little stiff, and then systolic dysfunction where the heart muscle will weaken, and the heart muscle may enlarge as it becomes ischemic, and then EKG becomes abnormal, and then last thing is chest pain. So exercise testing is the most validated predictor of cardiovascular events for all-cause death. And it's a relatively safe test if you pick the right patients. If you pick the wrong patients, there's, a real code called down there. So the rate of MI for stress test is probably 1 in 2,500. A regular treadmill test is relatively inexpensive, pretty fast way to do it. So if you look at normal EKG, and some of the exercise with absolutely normal tests, we're looking at the ST segments here. So that's the most common thing that becomes abnormal with treadmill testing, is that the ST segments may vary. But here we look at the PR interval and the ST segment, usually they're on the same level. And as you continue to exercise, they stay on the same level, isoelectric throughout treadmill testing. A lot of people will develop this rapid upsloping ST segment depression where the ST segment drops down here, but it's upsloping, you're going up a hill. That can be normal up to 1.5 millimeters of ST segment depression for somebody to develop that type of ST depression and not have coronary disease. And then, there's different types of upsloping ST depression. A minor slope there, almost a horizontal slope there, but slow upsloping. Again, those might all be normal EKGs. These are pretty abnormal. These are horizontal, clearly horizontal ST segment depression, where it's almost 4 millimeters of depression from the PR interval, from the PR segment here. Downsloping, where again, you're heading down a slope there, pretty abnormal. This is not usually what we want to see during treadmill testing. We'll stop the test right away. We see that. That's ST segment elevation with exercise. Which, if somebody already has a pre-existing Q wave or previous infarct, is a little hard to know if you should stop or not. Usually you can accept up to a certain amount of ST segment elevation with exercise if somebody has a pre-existing infarct in that region. So our indication is to stop treadmill testing. I'm not sure if I put a slide because I did this 4 days ago. I don't even remember what I did this morning, but our indications to stop treadmill testing are greater than 3 millimeters of horizontal ST segment depression will stop it. A really super hypertensive response to exercise. So the systolic blood pressure we thought is supposed to go up. If it goes up over 230, we'll usually stop the treadmill test. Severe chest pain will stop. Malignant arrhythmias like VTAC, obviously VFib, we're going to stop the treadmill and go to them. But that's usually our indication for stopping treadmill testing. Where the patient says they don't want to do it anymore, we'll do whatever they want to do. We'll talk to them about it before they stop. So abnormal blood pressure responses, again, if it's too high, if the systolic gets over 230, that's a hypertensive response. There's also hypotensive responses where the blood pressure drops with exercise. That's pretty abnormal. So if the blood pressure drops over 10, 20 milliliters of mercury with exercise and it stays down, that's a pretty abnormal response, and usually it's consistent with multivessel coronary disease or aortic stenosis. We'll see it with that. So somebody hasn't had an echo done in their hospital and they get on a treadmill for a stress test and they're just booked for a nuke and we didn't know they had severe IS. It's possible we can see that kind of response. So those are a couple of things we see with abnormal blood pressure responses. And then heart rate responses, typically the heart rate's supposed to go up with exercise, and usually it goes up, the target range we're usually looking for exercise testing is about 85% of the age predicted maximum. And that's it's 220 minus how old you are, that's 100%. And then we usually do 85% of that for our minimum level for exercise testing. And the heart rate's supposed to come down when you stop exercising. If it doesn't come down, it stays up. That indicates abnormal vagal tone. It has a high increased risk of mortality in patients who don't have abnormal heart rate responses for recovery as well. So usually with treadmill testing, we see about 10 beats a minute is supposed to come down when you recover. And if it doesn't, we'll call it, abnormal heart rate recovery. And usually it's just lifestyle modification, regular exercise, good blood pressure control. But it's an adverse, powerful predictor of independent events as well. So, what are the absolute contraindications of treadmill testing? Unstable angina, shocker, huh? So, usually when you have somebody on heparin, nitro, IV nitro, and troponins are 2, 3, 4, we're probably not going to want to stress test them. Active endocarditis, severe aortic stenosis for the reasons we talked about. Severe symptomatic aortic stenosis. We can do stress testing on people with severe AS, and often we'll do certain types of stress testing to actually quantitate the severity of aortic stenosis. But if they have severe symptomatic aortic stenosis, they're having chest pain, they're short of breath, they're having congestive heart failure, they passed out, we typically would, and that's an indicator you don't stress test people like that. Decompensated heart failure, acute pulmonary embolism. So sometimes you get these people that come upstairs, they have VQ scan ordered and a stress test order, which one are you doing first? If there's a consideration that somebody has a pulmonary embolism, it's the PE workup first. We shouldn't be putting somebody on a treadmill or stressing them if there's a consideration for pulmonary embolism. Acute myocarditis, pericarditis, usually we don't stress test people who have acute pericarditis. I usually want that treated and bring them back. If there's a concern about possible coronary disease, treat them for 3 or 4 weeks, get the pain to go away. They're off their non-steroidal at that point. You can stress them at that point. Acute aortic dissection, which I did treadmill somebody with acute aortic dissection once, but I didn't know he had an acute aortic dissection until afterwards. That's a scary thing.
How did that go?
He had severe shoulder pain for the whole test, before and after the test, and then I said we need to get a CAT scan. He gave him, and he was a 35-year-old with a dissection.
Oh, wow.
Yeah, kind of crazy. I was happy he did okay. Relative contraindications, so it means, maybe you do it, maybe you don't do it. Moderate to severe AS, certain arrhythmias, if they're like tachycardic rhythms, like rapid AFib, you probably wouldn't want to do it until the rate's controlled. Advanced heart block, hypertrophic obstructive cardiomyopathy with severe resting gradient. Probably, again, for the same reason we wouldn't want to do aortic stenosis where there's an obstruction of an outflow from the heart when you're exercising something is probably not a great idea. We will sometimes do exercise testing on hypertrophs just to see if they have a provocable gradient. So there's some people who have a hypertrophic myopathy and their resting gradient, what's considered severe, usually over a mean pressure of 40 and a peak pressure of 60 millimeters across an obstruction would be considered severe. So if their mean pressure is not severe, we might say, okay, this patient's having some symptoms of shortness of breath. Let's exercise them to see if the gradient goes up. Does it go up? Yes. Okay, let's treat them. How do we treat hypertrophic obstructive myopathy? Usually with negative inotrope to get the heart muscle not to contract so vigorously. So we'll give them beta blockers, calcium blockers, and then we exercise them again and see if the gradients went down. I've had a couple of patients that respond quite nicely to that. And then there's surgical ways to treat that as well with myomectomy to kind of relieve that. If someone is mentally incompetent and not able to participate in a stress test or consent, you're not going to do it. And if they come down markedly hypertensive, we're going to usually send them back upstairs, say, get the blood pressure better controlled, and we'll see what happens. Severe electrolyte abnormalities, severe anemia. Again, we're probably going to want all this stuff corrected before they come downstairs. Again, we talked a little bit about, we wouldn't want to do an exercise, just a plain exercise treadmill test on certain, again, left bundle branch block, you're not going to want to do that. Can't read the EKG. LVH with a lot of repolarization abnormalities. If the EKG is really markedly abnormal, you're not going to get much out of exercising somebody. DIG therapy, digoxin, because usually you get ST segment changes with just being on DIG, and then when you exercise it, they become more abnormal. Ventricular pace rhythms, Wolff Parkinson White. Probably the classic things we look at, probably not for plain treadmill testing. We don't usually do a lot of plain treadmill testing in the hospital. Almost everybody who has a stress test is an imaging stress test with treadmill testing in the hospital. What's the reason for that? I'll show you in a second. With plain treadmill testing, there's a lot of abnormals with plain treadmill testing, particularly in women. We see these, ST segments are dropped down a millimeter and a half horizontal, and we say indeterminate for ischemia. And then we don't usually do two treadmill tests in the same day. They wait another day, and then that's usually the delay there in treadmill testing without imaging is is not worth the difference in cost for the test. I mean, a hospitalization for another day versus a couple $100 for a stress echo. It's better just to image them when they're hospitalized patients. And this is the formula for, again, for the heart rate, people who are exercising, 220 minus the age is 100% of the target. We're usually trying to get to 85% of that. And the chart you can't read because it's just not well done. There's multiple protocols for exercise testing. Bruce protocol is the most common one that we use, but there's a modified Bruce protocol, there's a non-protocol. But the Bruce protocol is the most common protocol, and that's the protocol right there. So stage 1, they're going at 1.7 mile an hour at 10% grade, and in each successive stage, the speed of the treadmill goes up and the grade goes up. And usually, usually they get 10 or 11 minutes on a treadmill, and that's pretty good level of exercise. The other thing you might hear with exercise testing is this MET, which is a metabolic equivalent of energy expenditure. And for activities of daily living, we ask patients this all the time in our office, and for preoperative evaluations. Not everybody comes in for a preoperative evaluation going to get a stress test, but we'll talk to them. Are you able to walk up a flight of stairs? Can you vacuum your house, clean your house? And usually that's kind of like this 4 MET, which is like the golden spot for preoperative testing. So if the patient can do over 4 METs of exercise, 4 METs of activity without having symptoms, and they've had recent cardiac evaluations over the last couple of years, we don't usually repeat the stress test at that point. If they can't, they're in a wheelchair, they can't walk, they can't do much of anything, they're like at less than 4 METs, and often we'll do some kind of stress test before they have surgery to kind of assess their risk for having surgery. So that metabolic equivalent activity is kind of an interesting thing you'll see in some of the things you read about. It's greater than 10 METs. If they're able to do this, that's great. And it's a good level of exercise. And usually, the other bridges say, the guy was able to exercise 14 minutes on the treadmill, why we capping or whatever. Even people with coronary disease are able to go greater than 10 METs on the treadmill without symptoms. They do as well in medical therapy as people who have bypass surgery. So often, you have to pay attention not just to present, do they have coronary disease, but what are they able to do? What's their functional capacity? That's why we prefer to exercise them, because we can't figure that out with a Lexa scan test. We have no idea what they're. So if they're able to exercise, it gives a lot of information. When we talk about stress testing, we talk about what's the sensitivity of the test, what's the specificity of the test, and what's the prevalence of the disease in the population. You guys have seen this stuff before in your nursing? So, what's the sensitivity? It means, the patient has disease, what's the likelihood the test is going to be positive? So you want a test that's really sensitive, right? So if you have, if you're screening a population for cancer, you want that if you have a test that's positive, that it's going to be a correct answer on the test, right? You also want a test that's going to be specific, meaning, if the test is negative, they don't have cancer, they don't have coronary. So if somebody walks out of that stress test and they have a negative stress test, they don't have coronary disease, or they don't have significant coronary disease. And a lot of that depends on, you picking the right patients to do the test on. So you start picking on patients who, again, have low probability for disease. It throws off the sensitivity and specificity of these tests. When these tests were all designed in patient populations that had intermediate likelihood for coronary disease, that's why we see, they're relatively good tests for picking up disease. But you start picking patient populations that these tests weren't validated in, and you start throwing everything off a little bit. So what's the sensitivity of a plain treadmill test? 68% in an intermediate patient population. So that's not great, right? And it's 77. So if somebody has disease, you're going to pick it up 68% of the time. Somebody with a plain treadmill test. And if the patient has a positive stress test, a positive treadmill test, 77% of the time they're going to have some significant coronary disease. That means, a quarter of the time you're wrong. You gave them a positive stress test and or a negative stress test, and you missed it 25% of the time. So it's I have general distaste for regular treadmill testing in patients who I really worry about for coronary disease, and the insurance companies kind of push this a lot because of cost, But this is the reason. I have plenty of examples of really markedly abnormal nuclear stress tests where the EKGs didn't show anything. So, you know, but it's all cost. So you're looking on the boards, if someone is able to, on the board exams, if someone's able to exercise and they have a normal resting EKG and they're not on digoxin, the first thing you do is treadmill test them. And then if that's abnormal, you go to imaging testing. So many of them go on the imaging testing after they have an abnormal treadmill test. They have the insurance company says, plain treadmill test them, you can't do an imaging test first because we're not gonna pay for it. So we plain treadmill test them and it's abnormal, and then the patient freaks out for 2 weeks until we get them back into the hospital for the stress imaging test. It happens a lot, but that's the way it is. It's all about cost. So nuclear stress testing, I don't know if any of you have been down in a nuclear lab, but this is a dual head camera. There were single head cameras with the ones that I first saw when I first started training. But dual head camera increases the speed of acquiring data. It's a gamma camera, so when the patient's lying on the table downstairs, if you've been down there, that's not emitting anything. There's no radiation coming from that. The radiation is coming from the patient. And each of these heads has like a filter on it to kind of focus the radiations coming out of the patient and coming to the camera head. So they're called collimators. So the collimators are on the heads of the cameras, and the patient lies on the table and the radiation is being emitted, and each head of the camera is reading the information, and then it moves around the patient. And there's 64 pictures, but because there's 2 heads, it's 32 stops. So it stops 32 times, and usually each stop's about 25 to 30 seconds. So that's why the patient's downstairs so long. So that's one of the reasons why the patient's down there so long. The major reason is transport sucks, but that's another thing. So we use radio tracers. The most common radio tracer, the isotope we use for nuclear testing, is technetium. We like it because it's got high energy. It's about 140 milligauss for energy, where thallium's around 80. Thallium's the older one. So even though this has higher energy than this one gives off more radiation. And the reason, much more radiation with thallium test than a technetium test. And the reason for it is the half-life of thallium is 3 days, and the half-life of technetium 6 hours. So technetium is pretty much out of your system within 24 hours, where it takes, a lot longer for thallium. So if somebody's taking a plane trip and they got a thallium injection, they're gonna detect that at the airport for a long time. The reason why we like the higher energy, lower radiation, better pictures in big people is the higher energy. The only reason we like thallium is it's really nice for viability studies, because it gets into the heart muscle cell in a little different way than technetium does. So thallium gives us a better idea about myocardial viability in patients that have these severe myopathies. Is it worthwhile to bypass somebody who has an EF of 20%, 3-vessel coronary disease? Or is the heart muscle all dead? And if you revascularize and bypass the patient, they're just gonna have new blood vessels with no improvement in heart function. So sometimes we do these thallium viability studies to try to figure out whether or not the muscle's still alive there, and will it get better when you bypass the patient. And there's PET scanning. We really don't do any PET scanning here. It's a different type of camera, different type of isotopes. Anyway, I'll talk a little more about this. So this is the kind of pictures we get from a nuclear scan. When that camera comes around, they do this thing called Fourier transformation, and they reprocess and digitize everything. We get nice 3D pictures and tomograms of the heart. And this is a short axis view of the heart we get from that. And this is the septum, inferior wall, lateral wall, and the anterior wall. And we can assign a color basically to give us an idea how much radioactivity is being taken up by the heart. In this scheme, we use yellow and orange. So if the colors are really bright yellow and orange, the flow is great into the heart muscle. If it's like this color where there's no heart, that means there's no uptake of the muscle. So that's what a normal tomogram or short axis tomogram of a heart looks like on a SPECT image. And then when we're looking at other different views, this is called a vertical long axis view, where this is the anterior wall, apex, inferior wall. Again, this is that short axis view, again, the septum, the anterior wall, lateral and inferior wall, same heart. So what you've done here is just turned the heart on the end and taken one slice, like right out of the middle, and looked at it on end like a loaf of bread. So we look at it at stress, and we look at it at rest, and then we say, this is not great uptake. This is the color we're looking at for great uptake. and rest, this kind of gets a little bit better. So with exercise or whatever stress you pick, the inferior wall kind of struggles a little bit to get blood flow, and at rest it kind of gets better. So that's ischemia, inferior wall ischemia. And then we can gauge the studies. So we can get an ejection fraction off of it. This kind of is what that looks like when we kind of get a 3D image of the heart. We can look at regional wall motion, overall ejection fraction. Each camera does a little bit differently. The camera we have uses a Cedars-Sinai protocol. And I find that the numbers don't often match the echo numbers. I don't know if you guys have seen that. The nuclear camera, this protocol probably overestimates ejection fraction a little bit. So, for whatever reason. But anyway, it usually gives you a fairly reasonable ejection fraction number, or heart ejection fraction number. And it's kind of important because that's how we assess risk for stress testing. Is nuclear stress testing is size and severity of perfusion abnormality. So this is not severe, and it affects one area, the inferior wall. It doesn't affect the apex of the anterior wall. So the size and severity of abnormalities in perfusion, the size of the ventricle. Sometimes if somebody has a really abnormal treadmill test, this is the left ventricular cavity here, stress and rest. Somebody has really severe or a lot of ischemia, the ventricle will dilate huge, and you'll see what they call transient ischemic dilatation of the cavity, where this will get big and this is small again. So that tells us high risk, and then if the EF is low. So those are the things we typically look at for high risk nuclear scans. Yeah, so here's another inferior ischemia, same thing. So we were basically comparing the stress images to the rest images. So stress and rest, inferior ischemia. So sometimes you guys are seeing patients come up with just stress imaging. Stress image looks normal, right? So if the stress images are completely normal, the rest can't look any worse than that, right? So sometimes we can get away with stress-only imaging in patients. We'll do that. In a 2-day patient, somebody's big enough that we're doing 2-day nuclear scans. We'll try to do stress the first day, and we'll say, okay, if the stress imaging is normal, there's no reason to do the rest imaging. If the stress imaging is abnormal, it doesn't necessarily mean there's ischemia. Sometimes we see shadows because of diaphragm or because of breast getting in the way of seeing the heart, and we can't tell if it's an artifact of breast attenuation or diaphragmatic attenuation until we see the resting images. Well, how do we know that? So ischemia is an abnormality here that gets better with rest. Attenuation, it looks the same, stress and rest. The shadows, the effect is there, stress and rest. That's also the same thing that happens when somebody who's had a prior heart attack, right? You see a defect from a prior scar back here. It'll look identical in the rest images. That's not going away, that's permanent, right? You have a scar. So we can tell whether something's attenuation or scar tissue based on those gated images. So when we look at the heart moving, if the heart's not moving back there, that's an old heart attack. So there's lots of things we look at with these images to say, you know, this is scar, this is ischemia, this is attenuation or not. And then we can kind of risk assess based on size and severity of perfusion abnormalities, how many there are, how many vascular distributions there are. So this is inferior right coronary artery. But if there's inferior apex, that's like right coronary artery and LAD. If it's inferior in the sidewall, the heart all the way out here, then you got circumflex. So how many vessels are involved? So sometimes we'll say, oh, really small infrabasilar perfusion abnormality, like really tiny spot right back here. It's low risk because it involves like one small segment. We usually split the heart up into like 20 segments in nuclear scanning, and like 1 or 2 segments is abnormal. It's considered pretty small. And then we'll say, yeah, it's a low risk test. It only involves a small amount of myocardium. The overall heart function is normal. Ladies, 90, she said 3 interventions already. Her troponins are normal. Medical therapy, it's low risk stress test. Doesn't mean she doesn't have problems. It just means it's probably not worthy of putting her through another cath. So we have different ways of stress testing, right? We talked about exercise testing. We have pharmacologic testing. Adenosine was probably, this is the first vasodilator, dipyridamole. I used this when I first was in training. It stinks. It's an infusion over 4 minutes. You kind of watch you kind of try to gauge it so it gets over in 4 minutes. It's an indirect vasodilator. Its half-life is really long. People usually feel sick for like 24 hours after they get a med like that. We never use this anymore. Then adenosine came along, what a great drug. It's a coronary vasodilator, very short half-life, infused over, there's multiple different infusion patterns. We did it over 4 minutes here. Traditionally, it was studied over 6 minutes, so you infuse it over 4 or 6 minutes. And it has a very short half-life, but intense vasodilatation. Patients get beet red hot, very short of breath sometimes. And you'd see complete heart block because it's like adenosine, right? We give adenosine IV to break an SVT. This is the same drug, it's just not the same dose, but some people who have susceptible conduction system abnormalities can develop, high degree of block. Then we got into regadenoson, which is more of a selective vasodilator than adenosine is what we use now. This is Lexiscan. And it's a 2 minute injection, and we usually inject like almost the isotope almost immediately after we give the stress vasodilator. A lot less shortness of breath. We don't usually run into wheezing problems or people needing meds treatment down there, and you don't get heart block. You do see headache lasts longer, sometimes people can feel a little funny for a little bit longer. We can reverse any of these vasodilators with aminophylline, so sometimes we'll give 75 milligrams or 125 milligrams of aminophylline to reverse the vasodilator if somebody's just not feeling good down there after we do it. So vasodilator stress, only meant for nuclear testing, not meant for echo stress testing. It was tested a long time ago. It doesn't really give us any good information for stress echo. So this is only for nuclear testing. It's indicated for patients who don't do exercise and need pharmacologic testing. So these are your patients who can't walk, your patients who have a left bundle, your patients who have a pacemaker, patients who have Parkinson-like, patients, those are patients typically would get this type of testing. Don't want caffeine. You typically within 24 hours of the test if you can avoid it, because caffeine reverses the activity of this. Patients on aminophylline or theophylline, you don't want them on it because that's going to block the effectiveness for stressing as well, so you want to hold that. Patients that are on Persantine, Agronox, Persantine and Agronox, can augment the effect of this, so instead of reversing or blocking the effect, patients have more profound vasodilatation, they can get really hypotensive and sick down there. So hopefully it pops up on your drug interaction thing, but it's usually contraindication to giving. You have to hold the dipyridamole or Agronox before testing. The other way of pharmacologic testing is not vasodilator testing. So if you have somebody who adamantly refuses this type of testing, or they need to be, they had high degree of block list that they had, or you just can't give it to them because they have bronchospasm or something like that. We can do dobutamine testing for nuclear. So dobutamine is the type of pharmacologic testing we use for echo. That's the only pharmacologic testing for echo. And dobutamine is different than this because it's not a vasodilator, it's a chronotropic agent. I'll talk about that, I think, in the next slide. Yeah, dobutamine. So dobutamine is a beta agonist, so it increases heart rate, increases contractility of the muscle. It can be used for nuclear testing, but it's not our preferred way of doing it. For stress echo, it's perfect, because it increases, again, heart rate and augments contractility. And when we're doing stress echo, I'll talk about this a little bit. We're not looking at blood flow or perfusion like we are with nuclear testing. We're looking at contractility and wall motion. It's a functional test, more of a functional test than a blood flow test, which is what nuclear testing is. Stress echo allows for the dynamic evaluation of the cardiac structure. Let me go back to dobutamine. So dobutamine, there's a lot of different protocols. Usually the standard traditional protocol is 10 micrograms per kilogram per minute for 3 minutes, and then up to 20 for 3 minutes, and then 30 micrograms per kilogram per minute, and then up to 40 as a max. We do a more accelerated protocol downstairs where we'll start at 20 and then go to a peak at 3 minutes, go to 40, and then we give atropine. If the heart rate doesn't get up downstairs with dobutamine, we'll give up to 2 milligrams of atropine. We'll start with a 0.4 and then go 0.2 aliquots all the way to a maximum 2 milligrams. Trying to get up to the target heart rate for stress echo, typically we're trying to get that 85% number. That's why we usually don't like people to get beta blockers before dobutamine testing, because that's a real problem for dobutamine testing. We're trying to overcome that. So So stress echo is a dynamic evaluation of cardiac structure and function. It's not like nuclear testing, which is perfusion. Nuclear testing is all blood flow. We're looking at, you know, the function of the heart muscle, and is the wall of the muscle thickening and moving more vigorously under stress than it did at rest. And that's all stress and rest, and stress echo and nuclear testing. And we're comparing regional contractility, overall left ventricular function. Sometimes we're looking at pressure gradients, so, you know, like I told you, sometimes we'll look at aortic stenosis by stress echo. We have a group of patients that are low output, low gradient aortic stenosis patients. What does that mean? It means the valve doesn't move at all, but the EF is like 20%. So the ventricle doesn't generate much pressure behind the valve. So usually we say, okay, somebody has, you know, peak gradient or pressure gradient behind a valve of 60 millimeters of mercury, a mean of 40, they got severe AS. Well, those people that don't have any pump, they can't generate that pressure. They still might have severe aortic stenosis, just burnout aortic stenosis. So that pressure is like, if you put your thumb on the end of a garden hose, you can accelerate the flow through the garden hose, but you feel that pressure behind your thumb. That's what happens when you get an aortic valve narrowing, right? That pressure builds up behind the valve, and we correlate the elevation of pressure, how high that pressure gets with the severity and degree of aortic stenosis. Again, if somebody has no pump behind that valve narrowing, they can't generate any pressure, but they still could have a severely narrowed valve. So sometimes we'll give dobutamine to get the heart to kind of, you know, squeeze more vigorously and contract more vigorously. We see the pressure numbers going up with dobutamine infusion. We'll say, oh, pressure gradient went up pretty high with dobutamine. This lady has severe AS. Filling pressure, sometimes pulmonary pressure, somebody has mitral valve disease. So certain things we can look at with stress echo that we can't look at with nuclear testing. So I've had people come down for a stress test and for shortness of breath, and they had a left atrial myxoma. Like, shit, I wouldn't have seen that by nuclear test. You wouldn't see it because you're not looking at cardiac structure, you're just looking at those blood flow pictures. Or somebody has a large pericardial effusion, like, oh, I wouldn't have seen that by a nuclear test either. So there's certain things on stress echo that are, you know, beautiful to see, you know, or somebody has severe MR. Oh, I didn't know they had that. Maybe that's why they're short of breath. It's not coronary disease. So stress echo offers a view of something completely different than nuclear testing does. Nuclear testing is purely blood flow and coronary flow. Stress echo is dynamic function, but also valve function, pericardium, aorta. Oh, there's a dissection flap in the aorta. Oh shit, we shouldn't do the treadmill test. Send them back upstairs. So, you know, so sometimes this patient will come down for a stress test and they didn't have an echo order, and they see somehow, Dr. D put an echo order, and that's why, because, you know, really to do a full evaluation, there's certain things you just can't see by stress tests, by nuclear testing. You know? Nuclear testing is great because we don't run into some of the problems with stress echo we run. Some of the problems we run with stress echo is we can't see the pictures, or, you know, somebody's big and it's hard to see, it's grainy, you know, we had to give Definity to see it, or, you know, the guy's had 2 prior infarcts, and you're looking at wall motion, and you're saying, okay, the wall looks weak at rest because they've had a prior infarct there. Does it look a little more weak after they exercise? Or, I mean, sometimes those are really subtle things to tell, unless you have somebody who has a lot of experience looking at those things. It can be hard by stress echo to say somebody has ischemia on top of a prior heart attack that they've had. So, you know, for those people, we like nuclear testing. Stress echo is a nice test for somebody who's young, who doesn't have a lot of previous coronary work done, previous MIs. It kind of gives you a lot of information. You can kind of put it together a lot pretty quickly. It's a much quicker test, right? So it goes out for a stress echo. Again, it's stress and rest, right? So for stress echo, it's all done at the same time. We do rest images, rest echo images. We have those. We put them on the treadmill. They do their thing. We get them to jump off the treadmill and get pictures of their heart again within 60 seconds of stopping exercise. And it has to be within 6, that's how, while the heart rate's still up. And we compare the pre-exercise images to the post-exercise images. And then back upstairs, we have a report. Nuclear imaging, we have to decide whether it's a 1-day or a 2-day test, right? So how do we know that? Body weight. Because we only have a certain amount of radioactivity we can give a patient in a day. So if they're a big guy, a 300-pounder, or whatever it is, or a big-breasted woman, or whatever it is, we're going to make it a 2-day test because they're going to get 25 millicuries usually, or 25 to 30 millicuries on the first day, and the same dose, 25 to 30 millicuries on the second day. For a 1-day test, usually we give a low dose to start out with, so they'll get their rest dose, which is like 10, and then they'll get 25 millicuries for the second dose. And in the same day. We wouldn't give somebody 50 or 60 millicuries in one day. It's just not, it's too high of a dose of radioactivity in one day. And that's why it's split up like that. But you're talking about hours, right? The guy comes up, Scott comes up, or Krista comes up and injects the radioactive isotope. You wait 35, 45 minutes for it to circulate. They come downstairs. By the time security gets up there to get him, or whoever gets up there to get him, brings him downstairs. They lie on the camera, 32 stops, 25 seconds each. Wait for security to bring him back upstairs, or I'm sorry, they don't bring him. They bring him over to the treadmill lab. We're waiting for a lab to open up. They got to hook him up, and then we exercise and we inject the isotope again when they're on the treadmill, and then image them again after. That's 4 hours, 3-4 hours you're waiting. So it's a longer test, but there's certain things you get out of it that maybe you can't get out of stress echo. And this is what we look at with stress echo, right? We look at the heart in different views. This is what we call a parasternal long axis view, and then a short axis view. They're kind of the same thing we looked at in the nuclear test, where the heart's like a donut. And then there's long axis view, and there's different walls. There's the intralateral wall, anteroseptal wall, the mitral valve here, the left atrium. And then we look at it pre and post exercise. So here's the left ventricular cavity, this black area here. After exercise it should be smaller, right? Because the ventricle is really pumping very vigorously. The wall thickening, the back wall should get thicker. Anterior wall should get thicker as it contracts more vigorously. And we're watching this movement where it's contracting more vigorously everywhere. If we look at, we split the heart up into 16 segments on stress echo, and we evaluate each regional area for coronary disease. Here's an abnormal one, it's static. I don't have moving images, sorry. But if this is the short axis of the heart, septum, inferior, anterior, anterolateral wall, everything should come in more vigorously with exercise. It does here, except for this segment here. So we would say anterolateral ischemia, usually LAD or diagonal distribution, abnormal stress test. And again, you look at this cavity here, it's bigger after exercise here than it was at rest. And that usually is significant for a large area of ischemia. Limitations for stress echo, body habitus, COPD, ultrasound hates air. So somebody who's hyperinflated has emphysema, sometimes can be difficult to image. You think a skinny person would be easy to image by ultrasound. One of the most traumatic events in my fellowship was trying to scan a 25-year-old who was in a car accident. And I said, I don't need a sonographer. I'll do it myself because I loved doing that when I was a fellow. And I couldn't see anything because his rib spaces were so narrow. So I was getting all sweaty because the guy's looking for me. Somebody couldn't help me out. So anyway, sometimes you think it's the big people. Sometimes it's really the really skinny people by ultrasound. They're really hard because you need that window between the rib spaces to actually get the ultrasound to penetrate in. Breast implants are tough. And then stress cycle, I wouldn't say contraindication, but when we're looking at wall motion, the bundle branch block, the left bundle branch block, causes what you see on the ultrasound reports, paradoxic septal motion. So the septum kind of bounces a little funny way. People have left bundle branch block, and sometimes that's hard to tell the difference between that and what's called what a regional wall motion abnormality is with coronary disease, where the heart's not contracting vigorously. So that can be hard to differentiate sometimes. The same thing with wall Parkinson, why you get a funny contraction pattern. So we talked about sensitivity and specificity. That's treadmill testing. And then stress echo, sensitive 88% of the time, specific 79% of the time. So we're using stress echo even more so for specificity. Exercise nuke, sensitive 87% of the time, specific 73% of the time. That's probably some of the worst numbers. Usually it's probably in the mid-80s. You see most of this stuff. Often you trade a little sensitivity to specificity. So nuclear testing is more sensitive. It picks up usually more ischemic abnormalities than stress echo. But you get a lot more false positive. Not a lot. You get more false positive with stress nuclear study than you do with stress echo. If you see a wall motion abnormality in stress echo, almost always that's going to mean coronary disease. If you see a shadow on a nuclear scan, again, that could be ischemia, it could be diaphragmatic attenuation, because its diaphragm comes up high and it's covering up the back wall of the heart and you don't see it well. There's processing issues with the nuclear imaging, so they can create those abnormalities. So if somebody has an irregular heart rhythm, they can create it. So sometimes you run into some funny things, but again, if you have someone who's in the hospital, you're concerned about the possibility of coronary disease, these numbers, don't approach what you get here. And if you're depending on that to send somebody out of the hospital to reassure them, I don't think I'd feel as comfortable with a treadmill test, a plain treadmill test. Again, once you've decided this, each stress test is broken down to a stress component and an imaging component, right? So, the stress part of it, is it exercise or is it pharmacologic stress? If it's pharmacologic stress, is it Lexiscan, which is what we use here, or is it dobutamine? And imaging, are we doing a plain treadmill test, which you're probably not going to see much of here in the hospital, or are you using echo and nuclear? And that's the way we think about it. Sometimes I hear people say they're having a MIBI. I'm like, well, what does that mean? They think MIBI means pharmacologic. Now, MIBI means nuclear imaging. It doesn't tell you the type of stress you're doing. What type of stress are you doing? Are you exercising the patient, or are you giving regadenoson? And again, there's reason for choosing different ways to do this. Exercise is the preferred way of doing it. We don't exercise patients who can't walk on a treadmill because they have back problems or they're unsteady, or they can't get to that 85% of the target heart rate number. There are different protocols we can use other than the Bruce protocol. There are modified protocols which aren't this treadmill isn't get as steep or as fast, and we'll do that in some people who really want to walk them, but they have some orthopedic issues. Acridamol, adenosine, regadenoson are the vasodilator stress tests. Severe reactive airways disease and these AV conduction system abnormalities are really things we worry about with adenosine. And then caffeine, right? We don't want caffeine blocking the effect of our vasodilator stress test because we're depending on a good stress to tell us whether somebody has coronary disease. If we give somebody regadenoson and it doesn't vasodilate their coronaries because they've had coffee or Red Bull or whatever they have that caffeine in it within at least 12 hours of the test, then we're going to get a false negative stress test. And dobutamine. Dobutamine, it's a longer stress test. You're running into problems where people start developing arrhythmias down there, most commonly AFib. Sometimes ventricular arrhythmias like non-sustained VT because you're stimulating, you're triggering that stuff. And often we can calm it down with some beta blocker downstairs. Sometimes we can, and we got to send them to the ER if they're outpatients. I hate doing that, but it happens sometimes. And the inpatients will send back up to you guys and AFib and a cardioism drip, and like, what the hell happened? What did Dr. T do? For stress echo, they have to be able to get off. If they're doing treadmill testing, they have to be able to go on that treadmill and get off that treadmill quickly because we get that 60-second time frame to get the images. So if somebody's limping over there. I've carried a couple people over before. I don't know, but for stress echo, for our institution, when somebody has a stress echo order, we have so many new sonographers, but the sonographers that we've worked with long enough know that I want a quick surveillance of the valves. I'll ask them to scan the valves real quick and make sure there's nothing awful there. And some of the outpatients will do that, and I'll put in the report because it's not a full echo. We're just looking at the wall motion here. We're not doing a full echo interrogating the valve. So I'll say, aortic valve is trileaf and calcified, suspicious for aortic stenosis, recommend full echocardiogram for analysis of valvular function. But some places don't do it. They just won't leave it look at the valves. They're just doing so many stress echoes in a day. They're just doing what they need to do, and they don't. But I think it's important to kind of look at that. Yeah, so we talked about all this stuff, some of the issues associated with nuclear testing. It gets a long test, it takes a couple of hours. Again, I think the other thing with nuclear testing is radiation, right? So it's a fair amount of radiation for a nuclear stress test. It's more than a CAT scan. It's more than it's like 20 CAT scans. It's a lot of radiation. So if we can get away with doing one-day testing, lowers the amount of radiation because you get that 10 and 25 rather than 25 and 25. If we can get away with stress only, again, you're lowering it even more. we're trying to be more thoughtful about radiation dosing in some of these patients, so if we need a stress cycle, we do a stress cycle. So I want you to memorize that. Again, take home, most hospital patients will get a imaging stress test. Exercise testing is preferable to pharmacologic unless they can't exercise or they have some of those abdominal EKG things or they have a bundle or pacemaker. And we try to avoid like beta blockers before treadmill testing. We're trying to diagnose coronary disease. So if it's a diagnostic test we're doing, we're trying to say, does somebody have coronary disease? We really like them to be off nitrates and beta blockers if possible. If we're doing a test saying we know this patient has coronary disease, but we want to see if the medical therapy is effective for controlling it, then we leave them on. Most of the patients in the hospital are the first group, right? So we'd rather hold the beta blockers before a treadmill test, particularly antidote definitely. And off the IV nitro before they come down for stress tests. So that's it. I wanged it and I talked really quick. I'll take any questions. I will take any question on this. I'm ready. Anything. Nothing. You guys are experts. You'll teach the residents.